Well, greetings to you all. My name is Iain McInnes. It is my absolute pleasure to welcome you to another webinar from the Immune-Mediated Inflammatory Disease Forum, the IMID Forum. And on this particular occasion, I have to tell you, I've never been more excited about a webinar that I have been allowed to attend, never mind serve as chair. These are the extraordinary faculty who have very kindly gifted us their time and especially their knowledge and understanding. We'll come to them sequentially, but in order of presentation, we have Professor Carl June, the Director, the Centre for Cellular Immunotherapies, Director of the Parker Institute for Cancer Immunotherapy in the University of Pennsylvania in the United States. We have Professor Georg Schett, Vice President of Research and Head of the Department of Medicine. I've never understood, Georg, why it's Medicine 3. Presumably there's lots of departments of medicine, but you're in charge of the most important one in the Friedrich Alexander University in Erlangen, Nuremberg in Germany. And finally, Rich Furie, Chief of the Division of Rheumatology, Marlon and Barry Rubenstein Chair in Rheumatology in Northwell Health in New York, USA. But what I think is more important, that goes way beyond their titles, these are people who are the absolute global authorities in CAR T biology, CAR T cell biology, and in autoimmunity. And in Rich, we have one of the foremost both trial designers and analyzers in the world of inflammatory connective tissue disorders and the wider immune-mediated diseases. So, wow, and I'm just so excited to be with all of you today. These are my relevant disclosures. You're happy to read them and memorize them at your time and leisure. A couple of housekeeping remarks. Those of you who have graciously joined us, and I'm glad so many of you have, you'll be on mute for the duration of the meeting. However, there is a question and answer function. If you look at the bottom of your Zoom panel, there's a Q&A box. Click in that. Pop your question onto the box, and if we possibly can, we will answer the questions. And the rules are very straightforward. You know what they are. Whenever I'm in charge, if it's an easy question, I'll answer it. If it's a difficult question, I'll hand it on to the experts and make sure they're the ones who are sweating in this spotlight. If you've got any questions or any problems, technical in nature, please use the chat box, and the amazing IMID Forum backroom staff will sort everything out for you and make the world a better place. They'll also solve your technical problems. So what a great group to have underpinning this. So this is what we're going to talk about this morning, this afternoon, this evening, wherever you are in the world or whenever you happen to be picking up this webcast in the future. In case you had wondered what on earth this was, well, it's your welcome. So I hope you feel very warmly welcomed. Then Carl is going to take us through if you like, the fundaments of CAR T cells, the idea of what they are, why they are, what they will be, and all that goes with that. And then Georg will very kindly take us into the particular applications that he and his colleagues have been pioneering in the area of autoimmunity. And then finally, Rich is going to be that voice of clinical reason. He's going to set the context of all of this for us in the clinical the clinical environment and context. And then at the end of that, we've got generous time left over for questions and answers. So please, all the way through, do pop your questions into the box as they come to you. There's no such thing as a stupid question. And even if there was, it would be me that'd be asking it long before any of you. So thank you so much for joining us. And let's get on with the business of learning about CAR T cell therapy. An enticing possibility for us now in the future of therapeutics. So we're going to start by handing across to Carl. So if the backroom team can bring Carl on board and advance his slides, that would be absolutely marvelous. Carl, over to you. I listen and learn in anticipation. Thank you.
Well, thank you very much, Professor McInnes, and what a joy to be here today with this distinguished faculty. So my task, is to start off with some background on CAR T cells in cancer so that we have that as we delve into autoimmune diseases. And let's see. So my disclosures are here, and I'm going to show data from Novartis, and I'm the co-inventor of their marketed drug, which is Kymriah. So CAR T cells are stand for chimeric antigen receptor. They're named after the mythical Greek creature of three different animals. But the reason they're named as a chimera is, they're actually a chimera of a B cell and a T cell, giving antibody-based recognition to a T cell that has been optimized to kill other cells. So that's the background of their of how we got there with them. Whoops. So, the first trials started with so-called first generation CAR T cells in the first decade of this millennium, and then second generation CAR cells started at my center in 2010, and they became FDA approved in 2017. In this radar plot, you can see there are now 6 different commercially approved CAR T cells for blood cancers targeting CD19 and BCMA lineage antigens of blood cancers. What I like about this slide is it shows many biotechs in an alphabetical order going around this circle. And on the outer part are, phase 1 trials. And if you look up in clinicaltrials.gov, you'll find more than 1,000 trials of CAR T cells, and now more than 80 in autoimmune disease. And this chart shows something really interesting, which is in red, it's allogeneic cells. There are CAR T cells, TCR T cells that are allogeneic, some derived from iPSCs, some derived from cord blood. And then in green are autologous cells. And I think both of those are going to end up being useful for autoimmune disease, depending on the indication. But beyond CAR T cells now, there are T cell receptor T cells that are, commercially approved for sarcoma. And a major work is emerging with CAR natural killer cells. And those may have huge potential for autoimmune disease because they don't cause cytokine release syndrome, which is something that CAR T cells do in cancer patients. And then finally, tumor infiltrating lymphocytes, or TILs, have been just now recently approved for metastatic melanoma and are being tested in a number of other solid cancers. So a really vibrant area of new, medical therapies. So CAR T cell came out of in heme malignancies from bone marrow transplantation, and it most resembles that. It begins with obtaining with autologous cells from the patient. They can at this point usually it's done by apheresis. Although with next generation CAR cells, we're using so few cells because the cells are more potent that we can even just do phlebotomy to get cells in a doctor's office. There's a manufacturing step, which is for the commercially approved CAR T cells, last about 10 days, but there's release assays so that the vein-to-vein time from when you extract the cells on the upper right and then give them back to the patient is 22 days in the case of Novartis. But they now have a trial where there's 2 days of manufacturing, and then they're given back as soon as the release tests are met. So the trend in the industry is to shorter manufacturing. There are, we have trials here at the University of Pennsylvania with 3-day manufacturing, and in China there are trials with 1-day manufacturing. And as I mentioned, there's the allogeneic cells that are being used in many trials, which are in this case can be more off the shelf because they can be already made from cord blood or healthy donors or pluripotent stem cells, and then not require the apheresis and the time that it takes to manufacture cells. So our initial trials with a so-called second generation CAR targeting CD19 began in the summer of 2010 and published in 2011 in adults with refractory chronic lymphocytic leukemia. And then we treated patients with acute lymphocytic leukemia and both pediatric and adults, and then myeloma and so on as listed here, all with a 10 to 12-day manufacturing process and using a lentiviral vector to introduce the CD19 CAR. And this led to FDA approval in 2017. So we've now had follow-up of about of 14 years since the first patient was infused. That patient remains cured. He has no leukemia, and he still has CAR T cells and a B cell aplasia. So we've learned that you can have short or long persistence of the CARs depending on the patient and the design of the CAR cell, and the different indications have optimal times of duration of engraftment with the CAR cells. So the first two FDA-approved CARs were the T-Cell, which is the Novartis Yescarta, and then the Kite drug, which is Axicabra, Yescarta. So the Kymriah is T-Cell, it's a lentiviral vector. They both target CD19, and they have the same antibody parent, which is called FMC63. It's the single chain variable fragment that binds to the target molecule CD19 on B cells, both normal B cells and malignant B cells. And then they differ in their signaling domains, with one having 4BB and a CD3 zeta chain, and the other one's CD28 and a CD3 zeta chain. And they have very different persistence in patients. We now know that CAR T cells in about half of the patients treated with acute leukemia, they persist long-term, out to a decade or more, whereas the one with the CD28 signaling domain persists short-term. So this is very relevant to autoimmune disease in that we could, in theory, have cells that are programmed to persist different lengths of times in patients. So our first patient, as I mentioned, treated in the summer of 2010. We then analyzed him 10 years after infusion. He had no leukemia, and he very surprisingly still had CAR T cells. So on the right panel is an anti-idiotype stain on flow cytometry, and he had 1.29% of his CD4 cells were in the blood, still CAR T cells, and a smaller fraction of CD8 alpha beta T cells persisting, and he had B cell aplasia. So the CAR T cells had retained function for more than a decade. Yeah, and then we just published this work in Nature a few weeks ago from my group, and then with Rong Fan, who's at Yale, looking at 82 patients treated with our CAR T cells who had pre-B cell acute leukemia. And we found something very interesting in that study, that we could look at people who lost their CAR T cells, meaning they regained B cells, they didn't have sustained B cell aplasia. And we found that the patients who had sustained B cell aplasia had elevated levels of type 2 cytokines in their serum at the time we treated them. So they had increased levels of IL-4 and IL-13, for example, at the time of apheresis. And we've shown in this paper that IL-4 promotes CAR T cells to maintain the CD8 effector cells and delay exhaustion. So this is a cell extrinsic effect of, we infuse a population of cells that have the same CAR, but the individual cell function, it can be a CD4 cell or CD8, can be very different based on the biology of that T cell. So when we look now at leukemia, we've had, patients have durable remissions with leukemia, lymphomas, and myelomas. We can control how long the cells persist in patients. And we found out that the memory CAR T cells, at least when CD19 is the CAR, that those CAR T cells don't stay in the G0 phase of the cell cycle, unlike natural T memory cells, unless they're seeing antigens. So there's slow tick-over proliferation of CAR T cells when they have CD19, and that's how they maintain memory. So at this point, we have FDA-approved CARs targeting CD19 and BCMA. There are many, more than 100 different kinds of targeting constructs being evaluated in academic and biotech trials. more than 34,000 patients have been treated with these CAR cells. They've had a very strong safety record. There's very, very rare cases of T cell transformation after treating with autologous cells. There's a vibrant area of research with allogeneic CAR T cells and NK CAR cells. And there's lots of trials now using combinations of agents. And the main issue now is scaling this out, lowering the cost and automating the manufacturing with shorter vein-to-vein times. So there's a lot of work on next generation CAR cells. And on the top are the so-called next generation cells that have more potent effects in vitro, such as trucks, universal cars, self-driving cars, and armored cars. And I'll just mention briefly some of these. So trucks were named by Henrik Apken, when he was in Cologne. And it's a car that has a standard car design, but it then also encodes in the vector a cytokine that then is, genetically encoded within the CAR T cell. And then the CAR T cell secretes cytokine, which can both activate the CAR cell as well as stimulate cells in the microenvironment. And so Bileng Hu made a CAR, one of these trucks that had cytokines in my lab about 5 years ago, and it secretes IL-18, and that's an interesting cytokine because it's made in the NLRP3 inflammasome, unlike the common gamma chain cytokines like IL-2 and IL-4 that I've mentioned. And it has its own natural checkpoint, which is IL-18 binding protein, and which is made by non-T cells, and the IL-18 binding protein can terminate signaling by IL-18 cytokine. So we found it was very potent in preclinical mouse models, and now have tested it in a phase 1 trial of 21 patients who had refractory lymphoma. All of them had failed previous CARs. This is a second patient in our trial who had had 9 lines of previous therapy, including an autologous stem cell transplant, Yescarta, CAR T cell, and the BiTE blinatumomab. And she was treated with only 3 million CAR T cells. That's 100-fold below the dose of the FDA-approved CAR T cells, and she had very wide disease, as shown on this PET scan pre-treatment, and she's now actually 2.5 years out after treatment and in a complete remission. So these next generation trucks, in this case, are much more potent on a per cell basis than the commercially approved CAR T cells that are currently being used. So this is a phase 1 trial that we have here at the University of Pennsylvania, and there's many trials like this underway with next generation CAR cells that are more potent and should be safer. And so IL-18 here enhances CAR T cell efficacy, but it also reprograms the tumor microenvironment to activate macrophages and natural killer cells. So, solid tumors have not had such great results as we have had so far with blood cancers, and that's due to the more complex tumor microenvironment. We want to have CAR T cells that persist, that can proliferate and not be inhibited by this tumor microenvironment that's toxic. And so we want to have cells that are built to cure and built to last in patients. And there's lots of research in both academia and biopharma to make these kinds of next generation CAR cells. So besides trucks, there are CARs that are dual CARs that we have examples of trials here at the University of Pennsylvania. So there's the same T cell has 2 different binding molecules, antibodies, to 2 different targets on a tumor cell. And an armored CAR is one then that also can have other molecules, like we have one with a dominant negative TGF-beta receptor, so that it's insensitive to the inhibitory effects of TGF-beta. So we have a trial for glioblastoma. This is multiply recurrent glioblastoma treated with a CAR that binds EGFR and IL-13 receptor alpha 2. published earlier results of the first 6 patients. Currently, 14 have been treated, and all of them have MRI results showing shrinkage or resolution of their glioblastoma. So, and 3 other groups have published really exciting results this year in glioblastoma with CAR T cells infused directly into the brain. And then we've also been treating castrate-resistant prostate cancer that's metastatic in men with prostate cancer. And here we're using a CAR targeting PSMA, and it's armored so that it becomes insensitive to the suppressive effects of TGF-beta. And we've seen both toxicity and efficacy in that trial that we reported 2 years ago. So I think this year, based on what I mentioned, may be the year of breakthrough in glioblastoma, because these 3 groups at City of Hope in Los Angeles, Mass General in Boston, and in our center here at Philadelphia have all seen really striking results with CAR T cells delivered into the brain for glioblastoma. And there is this issue in the field, which is very relevant to autoimmunity and cancer patients, which is that there are rare cases where patients have gotten a lymphoma after being treated with CAR T cells. So the FDA issued a black box warning on this, and we could discuss the mechanisms of this effect perhaps later in the question and answers at the end. So secondary malignancies in patients treated with CAR T cells are rare. We've looked at 1,500 patients at depth at Penn and Stanford, and we've not had a single case where there's been lentiviral integration causing insertional oncogenesis. And basically it comes down to patients who have had 1 blood cancer are at risk of having a second one, about 5-fold above the population-based risk. And then there's this epidemiologic issue called immortal time bias, which is once these patients used to die, these refractory patients, and now they're getting treated with CAR cells, and now they live long enough to get the secondary cancer that they were destined to get anyway before. So this is some background that's relevant to autoimmunity. So there's lots of work now with CAR cells outside of oncology, and I won't talk about that today because you're going to hear from Professor Schett about autoimmunity. And it's just an amazing thing to the field, and he's going to discuss this in detail about how CAR T cells, the same ones that we use to treat cancer, can be effective for autoimmunity. So CAR T cells are living drugs. They have very different PK and pharmacodynamics than standard medicines. They have promise now beyond cancer for autoimmune disease. And these autologous T cells can be a living drug that can persist for more than a decade in cancer patients. And with that, I'll turn it back over to Professor McInnes.
Carl, thank you. A tour de force. I have to say that both the historical and the extraordinary innovative journey that has started in the cancer field and so beautifully setting the scene for what we're now hoping might be possible in the field of autoimmune disease. So thank you. That was crystal clear and truly authoritative. So wonderful. We're going to move straight on to a presentation now from my dear friend and colleague over in Erlangen, Professor Georg Schett. As has been appropriately and properly intimated, Georg has taken this extraordinary technology and thought again about how we could maybe apply that in the field of autoimmunity. Georg, really looking forward to hearing what you've got to say. Over to you, sir.
Yeah, thank you, Ian, and for the invitation to this august group of people. And I also want to thank Carl for this introduction talk, and Carl also for his actually pioneer work in the CAR T cell field, which had made it possible to translate, though substantially later, 10 years later, this therapy to autoimmune disease. I don't see my slides yet. Maybe you can share them.
I see them.
Perfect. Thank you so much. Autoimmune disease are highly chronic conditions, and they usually follow patients over their life. And I want to share this first slide, which does not move. I hear my disclosures, which shows Renoir, who had rheumatoid arthritis, which is a typical autoimmune disease. And at the time Renoir had rheumatoid arthritis, there was only aspirin available. Aspirin improved his symptoms, but it was not safe. It did not control the disease process, as you see when you look at his hands. So this is a chronic inflammation destroying ultimately the organ, in this situation, the joints, and it did not at all eradicate the disease. And the situation has been not acceptable, and I think one of the, next to glucocorticoids, one of the key advances in treatment of autoimmune disease has the development of monoclonal antibodies targeting cells or cytokines. And the key insight from this development has been that there is not a complete redundancy. There are master pillars which symbolize a cytokine, and they basically are necessary to turn the inflammatory wheel of autoimmune disease. And if you cut the master pillar, then this inflammatory wheel cracks down. And that has been a completely new concept, because it has been always considered that inflammation is extremely complex, and when you take out one component, this is not sufficient to influence the process. And the second insight has been that these master pillars are very different among different diseases. So it allowed actually a kind of molecular phenotyping of inflammatory diseases. Now, the limitation of current available drugs in autoimmune disease is not that they improve the symptoms, they don't improve the symptoms, or they're not safe. They're very safe, they improve the symptoms, and they also control the disease process and preserve organ function. However, they don't eradicate disease. Usually, these drugs have to be given lifelong. It's a kind of a suppressive setting of treatment. The disease is still there, and if you stop, it has been very nicely shown, if you stop the drug therapy, usually disease comes back. And that's fundamentally different in other field of medicine. When you think of the talk of Professor June and leukemia, for instance, you have to eradicate leukemia, otherwise the patient, the disease kills the patient. And there is basically a short-term treatment, a very aggressive treatment, and that leads actually to abrogation of the disease. So there's true absence of disease. And this is a visionary scenario, what we start to follow now, I think, in autoimmune medicine. Why is that important? Because as said, autoimmune diseases are extremely chronic, trigger a persistent inflammation in the organs, and which triggers actually accruing tissue damage, leading to organ dysfunction. And one of the key factors which drives that process are autoimmune enhancer loops, which are positioned in secondary lymphatic organs or the affected end organs, which are based on the generation of autoimmune B cells, which trigger autoantibody deposition in the tissue that lead to inflammation. Now, that autoantibodies and B cells are at the root of autoimmune disease is symbolized in this slide, which shows actually autoantibody generation during the process of lupus. And you can see that these autoantibody entities, each line represents one, are forming long before the patient presents with clinical disease, which is symbolized by the vertical line here. So that means that actually the B cells are at the root of the autoimmune disease process, producing antibodies long before actually the disease starts. And therefore, B cell targeting has always been a highly interesting concept in autoimmune disease, and Professor Furie will allude to that in the next talk. Now, the way to deplete B cells can be different. CAR T cells is definitely one of the probably the most powerful approach to deplete B cells from the body, indicated at the top, and show that there is not much residual B cells left. Bispecific T cell engager or short T cell engagers are interesting approaches, which are also now moving more and more into autoimmune disease. And the classical way to block B cell in the body to date in autoimmunity is B cell depleting antibodies such as rituximab or more modern antibodies, which have higher affinity to B cell and kill better B cells in the human body. Now, we had the typical situation that we still have limitations to treat autoimmune disease, particularly challenging young women suffering from lupus. And this young woman was the first receiving CAR T-cell therapy in autoimmune disease in 2021. She was 20 years of age, had affection of kidneys, heart, lung, joints, and the skin. And she cycled through many drugs, among them very potent and also toxic drug like cyclophosphamide, and also severe T-cell targeted drugs like tacrolimus and mycophenolate, and also B-cell targeted drugs like belimumab and rituximab. Despite all this armamentarium of treatment, she has a very active multi-organ lupus. And therefore, we decided to go into CAR T-cell therapy with this young lady who had an entrepreneurial character, also to go this way with us. And the approach has been an classical autologous CAR T-cell therapy where you take and Carl, June has alluded to that, where you take leukocytes from the vein, you enrich for the T cells, you transfect them with a lentivirus, leading to the generation of CAR T cells, and then you expand them ex vivo, a process which took 12 days, and a fresh approach where we actually then, which ended in a short infusion of CAR T cells into the patient with a target CD19, which is first very highly specific for the B cell lineage, and then it is also expressed by a large variety of cells of the differentiation stages of the lineage, from early precursors until plasmablasts, which are key autoantibody producing cells. Now, this infusion was well tolerated, and that was also a very important finding because we were scared that autoimmune T cells could actually worsen the disease, but this didn't happen. Instead, there was a substantial proliferation of the CAR T cells, which you see here from 0.3 to 27% of all circulating T cells within a week, suggesting there is target cell engagement. Basically, these CAR T cells recognized the B cells and killed them and started to get activated and proliferated. We call it also the homeostatic proliferation of CAR T cells, which is also found in cancer treatment. Now, lupus resolved quickly, and this is indicated here with the complete absence of B cells after this red dashed line, which symbolizes the CAR T cell infusion, the seroconversion of double-stranded DNA antibodies, the normalization of complement factor levels, and the abrogation of proteinuria. Now, the interesting part of CAR T-cell therapy for us, which was really a very unusual observation, is that the disease didn't come back after the single infusion, despite we stopped with the infusion or even before the immunosuppressive therapy and the glucocorticoids. And this patient is now more than 3.5 years in complete remission. We have here the 1,000 days anniversary, which was celebrated in December 2023, and she is without drugs, has no signs of autoimmunity and no signs of disease. And despite the recurrence of the B cells in this young lady, you can see here the B cells came back about 150 days after the CAR infusion and stayed. So there is no B cell depleted state in this patient, which continues. That means that the CARs are also dysfunctional or dead, and the the functionality of the immune system is at least to some extent restored. This finding actually created a substantial interest in CAR T-cell therapy in autoimmunity, and here is just to symbolize there are patients here in the bottom with myositis, lupus, and systemic sclerosis. All of them have been treated with CD19 CAR T-cells. All of them are drug-free and glucocorticoid-free over 1 year at least. Some of them over 2 years. Two meanwhile of them over 3 years. Only one patient relapsed out of these 15, so relapses are existing. That's normal in medicine, but still the majority of patients, over 90%, stays in a drug-free state, which is very stable. And that's very remarkable because usually conventional treatment, you can hardly actually get off this treatment without a substantial risk for relapses. Now, what is also interesting in these diseases, in classical autoimmune disease like lupus, responses are very deep. Here, for instance, the young lady with severe skin manifestation of lupus and nephritis, you can see this by the edema in the face, and a massive improvement of all these symptoms of organ involvement in lupus. What you can also see that in patients with myositis, who often suffer from substantial interstitial lung disease, which can be a life-limiting step or situation in this patient. And you can see that here on the right with this massive accumulation of FAP tracer in both lungs. They profit substantially from CAR T-cell therapy, leading to an improvement of lungs and the muscles in often very severe cases of myositis. And the third example for deep responses is interestingly systemic sclerosis, where people didn't believe so much that B-cell play a role, but it's still a very autoantibody-driven disease. And you can see here the improvement of heart and lung involvement in patients, which is very severe and goes ahead with a very poor prognosis. And for these patients, CAR T-cell therapy seems to be a very interesting option. Also, you can see that partially the original architecture of the skin is restored over time. And so there is a learning curve now. What happens with actually in the tissue when CAR T-cell therapy is employed? Do you actually get some healing in the tissues also, which is particularly important for systemic sclerosis? Now, why is CAR T-cell therapy interesting? Because it appears to deplete actually the entire B-cell pool within a short time in the patient, and only plasma cells are surviving that because they don't express CD19. If you take a CD19 CAR T-cell therapy, they stay, and then you basically build up a new B-cell system which lacks the autoimmune B-cell clones, and therefore you typically see a seroconversion of disease-associated autoantibodies. Now, this concept is interesting because, in contrast to hemato-oncology, in autoimmunity, the recurrence of B cell is rather fast. Within 50 days, 100 days, they come back very consistently. They come back after this deep, narrow valley, which is here up to, say, 50, 100 days. B cells come back, and the patient does not live in a B cell depleted state years after CAR T-cell therapy. Now, these B cells are, when they come back, they are naive B cells. So the patient lives with a naive B cell system. This is shown here. There is a baseline early reconstitution and late established reconstitution. That's 1 year after CAR T-cell therapy. And you can see there's a very a strong preponderance of naive cells and almost no memory cells. So you basically, that the idea of this reset concept comes from that you replace actually a memory B cell pool with a naive pool. That is also observed to some extent in monoclonal antibody-based B cell depletion, but we think that's much more pronounced in the CAR T cell approach. And this is also supported by lymph node data. When you look at the secondary lymphatic organs and look in the tissue what CAR T cells are doing, they are wiping out the entire follicles. And you can see that here, that's a lymph node biopsy from patient receiving CAR T cells. And here you can see that the brown staining is gone, which is CD19 and CD20 staining the B cells, and you can see there is no B cells in the tissue anymore, while it's full of B cells in rituximab patient with full peripheral depletion of B cells. So it's very interesting that there is a qualitative difference, obviously, and a quantitative difference in CAR T cell mediated B cell depletion. The qualitative difference is based on the fact that the follicles are not anymore present. Why? Because also the organizational structures of the follicles, the follicular dendritic cells, which are stromal cells organizing the follicle and are dependent on the presence of B cells, are gone. So this is a very interesting finding, and we start to understand what happens in this patient, because in these patients probably you don't get actually the presentation of autoantigens anymore, and therefore this is an additional component that the autoimmune disease process seems to break apart. This is supported very much by studies on the T cell part of the autoimmunity. So these are, for instance, data from RNA sequencing from T cells, looking at differentially expressed genes. And what you see here is that when you shift to the left, that means these are genes expressed less dominant after CAR T cell therapy in T cells. And this is the typically type 1 interferon gene. So this type 1 interferon response, which mimics which is a sign for T cell activation in autoimmunity, is breaking apart. Now, when you look at the B cell lineage, starting in the bone marrow, going into secondary lymphatic organs, and some of the cells, plasma cells, go back to the bone marrow, CD20 actually captures quite a large part of the B cell lineage. But CD19 is even broader. It captures early B cells in the marrow and also plasmablasts, which are antibody-producing cells, but spares the plasma cells. And this sparing of plasma cell, which have other antigens on their surface, but not CD19, they have, for instance, BCMA, may be important to keep a certain immunity in this patient present, which might be important for infection control. For instance, when you look at vaccination and related antibodies against classical vaccination viruses and bacteria, here pneumococci and rubella, mumps, measles, tetanus, and SARS-CoV-2, you can see that these vaccination responses remain stable despite you deplete actually CD19 positive B cells completely from the system, but they are kept by the plasma cells. And the plasma cells are CD19 negative, and these antibodies are primarily generated from these plasma cells, which maintain a certain immunity against bacteria and viruses in the patients. Now, from the safety standpoint, CAR T cell therapy has long not gone into autoimmunity, probably because of the risk of cytokine release syndrome, which can be sometimes severe in B cell malignancies due to a large B cell burden in this patient. And this B cell burden creates a substantial activation of the infused CAR T cells, which can lead to a massive cytokine release. And shock-like situations. This is now much better controlled in hemato-oncology, but in autoimmunity, the interesting component is that the B cell burden is much less pronounced than in cancer, and therefore, usually, cytokine release syndrome is not considered a big problem in autoimmune disease treatment. With CAR T cells, here you can see fever in the first, or body temperatures in the first 10 days, and you can see that there is an increase. There's fever in the first days after CAR T cell infusion, which is symbolizing cytokine release syndrome grade 1, which is a mild cytokine release syndrome that happens. That's related to the activation of the CARs, but it's not actually severe, and that's making it actually much more feasible to use CAR T cell therapy in autoimmunity. This combination of efficacy and safety in a few patients with a severe autoimmune disease has triggered a substantial trial landscape. Carl June has mentioned that there are now 70 to 80 trials. There have been about 40 in the beginning of the year. So there's a very dynamic process happening now worldwide, in China, in the US, and in Europe. And this stimulates also a new concept, especially the treatment of very sick children. Here are two examples with very severe lupus in children 15 years of age, which is usually associated with a lot of organ damage and organ failure, particularly hemodialysis. And you can see here in this example, the patient has underwent kidney insufficiency during the production process of the CARs, had to be hemodialyzed, and in the hemodialysis the patient got the CAR T cells, and the kidney function normalized, and the lupus disappeared. So that was just at the right time, at the right place to use this therapy. And also newer data now suggest that you can clean kidney glomeruli from IgG and C3 deposits by CAR T cells, which is very exciting that you might save organs very early in life in severe patients. And the other part, and that's also alludes to Carl June talks and on the possibility of CARs to go into the central nervous system, is particularly interesting for those patients who have central nervous system involvement of autoimmune diseases, primary autoimmune diseases in the central nervous system, but also peripheral autoimmune disease, which actually trigger severe inflammation in the central nervous system, which is usually not included in any of the studies. And it's also challenging because many drugs do not go into the brain to treat them. And here I want to just share with you this very sick young man who had a severe transverse myelitis due to lupus and was bedridden at the age of 20 with a basically inability to sit up and move his legs, based on lesions in the brain and in the spinal cord, despite actually multiple very effective drug therapies. And you can see here that the patient had a hyperreflexia and a positive Babinski sign, which is related to a central nervous system inflammation and dysfunction. And the efficacy of CAR T-cell therapy in the central nervous system seems to be very strong, because they go into the brain, and this patient had complete peripheral B-cell depletion, but in the cerebral spinal fluid, there were still B-cells present. They were completely eradicated, and that led to a disappearance of this lesion in the brain and to a regression of some of the spinal lesions, with a functional improvement of the patient. And the patient, after about 6 weeks, could start to walk with help. He's now much better and can walk with sticks already. So that allows actually also severe CNS disease patients to enjoy improvement. CAR T-cell therapy, and this is the end of my presentation, I think is in autoimmunity is still in its infancy. There are several frontiers which have to be addressed, especially the patient selection is probably the most critical frontier. Which patients would profit most from CAR T-cell therapy? But also other procedural points are important, like target selection and the necessity of lymphodepletion. Most of the studies have been done with CD19. There are a few studies done with BCMA now, which depletes also the plasma cells. Most studies used standard lymphodepletion regimen, but one might think that you do not need the full dose, and you can also use smaller doses of lymphodepletion. Procedural events are also concerning the stop of immunosuppressive therapy, which is, I think, important, and the management of toxicities, which the field profits a lot from the work done in hemato-oncology. And then post-procedural challenges and frontiers are the monitoring, which is actually quite well established. You can monitor CAR T cells, you can monitor B cells, you can monitor autoantibodies or immunoglobulin levels. And then treating relapses is completely in its infancy, but this is also a very interesting field, and I think more will be learned in the next year. So that's summing up this this translation of CAR T-cell field into autoimmunity. We see an accumulation of young people who are off their disease. the interesting part is that these patients feel not anymore as patients, right? And that's an interesting concept because we always speak of our patients and they have a lifelong label of patients, right? To be patients. But these patients who had actually no these drugs anymore over years and no disease, they don't feel themselves anymore as patients. They got rid of their disease. And I think this concept is very fascinating. And if we can manage this to allow this in a good proportion of autoimmune disease patients, I think we have made a big step forward, and I think the next years will learn us or teach us how effective and safe this concept is. So thanks for attention.
Yeah, wonderful, Georg. Thank you. It's an extraordinary medical story. We have learned a great deal already. I think what I hear you saying is we have a lot more still to learn, and we're hugely in your debt for sharing that discovery journey with us today. So thank you. As I say, we're going to have questions and answers later. There's some brave people who have already started to add some questions and answers. There are plenty of other thoughts in your mind, I know that. So please feel free to pop them into the Q&A session. And in our final part of the webinar, we will be taking those head on. The last formal presentation part of our webinar, though, is going to come from Professor Rich Furie. Rich is, I think, well known to many of you, one of the doyens of trialing in the inflammatory connective tissue field. And we asked Rich just to think a little bit about where this CAR-T therapeutic might sit amidst all the other opportunities, of course, because there are other things being thought about. So, Rich, it's a pleasure. Looking forward to hearing what you've got to say. Over to you.
All right, thanks, Ian. So I was given the difficult task of sticking a pin into the balloon. So my talk is about risks, reservations, opportunities, alternatives. And despite hearing the amazing biology, the amazing clinical outcomes, I'm going to sound like a curmudgeon, I hate to say. Disclosures. And so in the next 20 minutes, this is what I'll talk about: risks, the reservations, and alternatives. All right, so I went to my first CAR-T meeting along with nephrologists. There are a bunch of rheumatologists there, and this had to be about 3 or 4 years ago. And when the oncologist started to tell us about some of the safety issues, we all panicked. But then when we started to see some of the cases, Georg series, and actually a series that started about 40 miles to the east of where I'm sitting, we became a lot more comfortable. And this is the second series. So this group at iCell has treated about 12 lupus nephritis patients with a different CAR, a BCMA CD19. So the question is, what is the truth? And I'll discuss a little bit about that in the next few minutes. So I've divided my talk into 3 areas: pre-treatment, peri-treatment, and post-treatment. And starting with some of the issues pre-treatment, there's no question that when you're doing cell therapy, it requires synergy with hematology oncology. And that doesn't always happen so easily, mainly because the oncologists are very busy with their own programs. A second issue is, who is the ideal patient? And Georg talked a little bit about this, and how is refractory being defined? Because right now we're studying refractory patients, typically patients with refractory lupus nephritis. And then another problem that we're facing is, if we're taking in a refractory, very active lupus nephritis patient, we need to reduce or even stop some of their medicines prior to apheresis. And I must say, that makes us nervous. As far as issues peri-treatment, does the construct itself or the method of gene insertion affect the efficacy or the safety? And a problem that I'm facing, a couple of patients that I thought would be very appropriate balked at being in the hospital for 7 to 10 days. But there's really no way around that. And on our minds, the lymphodepleting regimen, how much, how necessary? I mean, it seems like a necessary evil. And how safe is it, short, intermediate, and long term? And a question that comes up, though we're quite familiar with cyclophosphamide, we're not really very familiar with fludarabine. So fertility issues come to mind. And we'd actually like to know what the contribution of lymphodepletion is to the outcome. So as I mentioned, we have an experience with cyclophosphamide, the NIH regimen, or the Euro-Lupus regimen, which is just 500 milligrams of cyclophosphamide, though given every 2 weeks for many doses. Fludarabine is something that's pretty foreign to us, though there was one trial in lupus nephritis at the NIH looking at multiple courses of fludarabine. And then post-treatment, we heard a little bit about cytokine release, which I think we can deal with. ICANS is a new one for us. Cytopenias, just like with rituximab, or for that matter with obinutuzumab, can occur, both thrombocytopenia and neutropenia. And then, will these patients need repeat treatment? And will that be equally successful as their first treatment? The T-cell lymphoma risk was discussed by Carl. It seems like a very low risk. But my main issue is regression to the mean, and we'll talk about that in a little bit. Regression to the mean, not only with efficacy, but also with safety, because we've heard unbelievable results out of Germany, out of China. Will that be universal? And then just general issues. I don't think we've heard about a regulatory path forward from the FDA or from the EMA. So will these be single-arm studies in refractory patients, or will a comparator be needed? And if so, what will the comparator be? Cost is high, for sure. And then we've heard the terms immune reset and cure, and we actually should probably have formal definitions of both. And how will cell therapy be incorporated into the treatment algorithm? Well, I think there's no question that early on it will be for the refractory patient. But if proven safe, and if it can really turn off the disease process, you'd want to start using it earlier and earlier. But there is a lot of competition. There are the traditional monoclonal antibodies, there are the T-cell engagers, and yet other strategies for getting rid of B cells. The experience in the United States is somewhat limited, and it hasn't really been exactly published. There are satellite symposia at some of our meetings. So the last one was at EULAR back in June, and we heard about a few cases, a couple cases from company Cabaletta and the other from Kyverna. And the efficacy seemed to be there. We heard a little bit about CRS, though I must say it seemed to be very mild with the Kyverna CD19 CAR. But then I found out through an unusual way about ICANS occurring in one of the patients. And this was a grade 4 ICANS, basically seizures in a patient with lupus nephritis. So it'd be really nice to have some kind of central registry, though I don't think that's going to happen, just so we know what's happening both on the efficacy side and on the safety side. And this is the case that I just told you about. All right, but there are other strategies. And don't get me wrong, I am a big believer in B-cell depletion for our diseases, such as lupus. We have monoclonal antibodies. So we've had at least 4 studies where we've given sequential belimumab and rituximab. You can modify the target from CD19 to from CD20 to CD19 or the BAFF receptor. BCMA is being studied, and CD38 is being studied in lupus as well. And I'll show you some data where an anti-CD20 was engineered for greater antibody-dependent cytotoxicity. Cell therapy you just heard about, so I'm not going to go over that again. And then there are the T-cell engagers, which I find very interesting. So let me tell you about obinutuzumab. Obinutuzumab is a type 2 anti-CD20, and it's been around for a while. It was approved for CLL in 2013. It's a far more potent antibody in depleting B cells than, say, its predecessors like rituximab. In fact, the antibody-dependent cytotoxicity is about 100-fold greater than rituximab, but it also has greater direct cell death. There's no dependency on complement-dependent cytotoxicity. And it's been shown that there's greater B cell depletion than rituximab in tissues and also in vitro using lupus blood. And then in head-to-head trials against rituximab, obinutuzumab was superior in the treatment of B-cell malignancies. So the question arose many years ago, should we do another trial like we did with rituximab? So remember, the rituximab lupus nephritis trial was called LUNAR. The obinutuzumab lupus nephritis trial is called NOBILITY. And we published this a couple of years ago, and I'm just showing you top-line data. And you have to remember our effect sizes in lupus are low, and that's a story for another day. But you can see the complete response rates in proliferative lupus nephritis at 3 different time points, 1 year, 1.5 years, and 2 years are up on this slide. And the maximum was at 1.5 years, week 76, with an effect size of 20 percentage points. And that was about 1 year after the second course of obinutuzumab. And about 4 or 5 weeks ago, there was a press release about the phase 3 obinutuzumab study in lupus nephritis, and that study was called Regency. The data will be in the public domain in a matter of months, so hang in there, but it was a positive study. Now, what about obinutuzumab and B-cell depletion in the tissues? One of the problems that we had with rituximab is you could see B-cell depletion in the periphery, but if one looked at the tissues, at lymph nodes, B-cell depletion wasn't occurring. But obinutuzumab was studied in a similar fashion as rituximab in taking patients who were about to undergo a kidney transplant and then harvest lymph nodes from them at the time of surgery. And this particular population had a history of sensitizing events such as blood transfusion. And there were about 25 patients included in this study. You can see cohort 1 and cohort 2, but the bottom line is they at least got 1 dose of obinutuzumab, and most of them got multiple doses of obinutuzumab. And a busy slide here that I'll go through somewhat quickly. If you look at the left, you can see the B cells in the lymphoid tissue pretty much depleted with obinutuzumab, except for those 2 patients. So those are the black circles. The open circles are the comparator. And then looking at the various B cell phenotypes on the right-hand side, you see basically a similar pattern. There's significant B cell depletion in the tissues, except for a couple of patients. This is a very important point, so I'm switching gears. And I think anybody who's interpreting lupus nephritis trials or designing a trial needs to go back in the literature and read Anna Malvar's article. It's now about 8 or 9 years old. Anna's a nephrologist in Buenos Aires, and she did a study in lupus nephritis, basically a second biopsy study. So the patients were appropriately treated for the lupus nephritis, and they underwent a second biopsy about 9 months after their induction. And the overall message is that proteinuria is a terrible endpoint, and it is, but it's the best that we have right now. But I'm going to show you 2 slides, and here's the first. The response rate, the complete renal response rate, using our typical definitions, was about 40% in her cohort. But if you look at the slide and each circle represents an individual patient, you can see when the histology was evaluated that about 50% of these complete responders still had histologic activity on their kidney biopsy. The flip of that is that one could be a histologic responder, which occurred in 20% of our cohort, but still have significant amounts of proteinuria. So when someone participates in an interventional trial in lupus nephritis and they still have proteinuria, you don't know whether that was from pre-existing damage, ongoing inflammation, or both. And so I think a very important point is that patients need second biopsies to try to figure out exactly what the response was. Now, there are some novel constructs that intrigue me. We have T-cell engagers, mosunetuzumab and blinatumomab, and I'll just describe those in a bit. And yet there are other strategies. There are bispecific killer engagers, trispecific, and a whole assortment of novel strategies to deplete B cells. All right, so a frenemy, I don't know if that's a word you're familiar with. My wife taught me that when a neighborhood cat jumped through one of our windows, taunting our indoor cat, and that was the frenemy. But here's the target on the right, the B cell. And here's the frenemy. The frenemy is a bispecific antibody. It binds CD20, it binds CD3. And in binding CD3 on T cells, it activates the T cell to the point that the T cell is capable now of killing a target. And the target, of course, that it's going to kill because of the bispecificity is CD20 on the B cell. And the B cell disappears. There are a couple of B cell engagers that have been used in rheumatology. One is mosunetuzumab in a phase 1 study in lupus, and that's a bispecific CD3, CD20. And there's blinatumomab, which is a bispecific CD3, CD19. And we'll hear about the mosunetuzumab study probably within a couple of months. It was a phase 1 study in lupus. And then there was a recent report in refractory rheumatoid arthritis, basically studying 66 patients with blinatumomab. And you can see some of the pharmacodynamic data in the bottom left. There's B cell depletion. And then in the middle on the bottom, you can see the DOS response for the rheumatoid arthritis. And then on the far right, before and after synovial biopsies with depletion of B cells. So how do we put this all together? Well, starting on the left-hand side of this slide, it seems to me that cell therapy is probably the most potent way to kill B cells. But I'm not sure the bispecific T cell engagers are that far behind. And for that matter, monoclonal antibodies, and we have a bunch of monoclonal antibodies that are far more robust in B cell depletion than rituximab. We have obinutuzumab, as mentioned. We have ianalumab, getting harder to pronounce as well. Ianalumab, which is an anti-BAFF receptor, and under study will be anti-CD19 antibodies and anti-BCMA antibodies. Then if we turn to the middle of the slide, safety. Well, I do think monoclonal antibodies perhaps are the safest approach here, followed by the T cell engagers, and followed then by cell therapy. But if we go to the right-hand side, there's no question that cell therapy involves a lot of resources, a lot of manpower, and that certainly drives up the expense. T cell engagers seem a lot easier. In fact, some of them are sub-Q, and monoclonal antibodies, we are now used to giving monoclonal antibodies for sure in our patients with rheumatic diseases. So the questions that arise, what degree of depletion is necessary to treat lupus? This is not cancer. Maybe we don't need to deplete every single B cell in the body. And the question that I have is safety perhaps compromised with greater B cell depletion? But looming over all of this is there's so many therapies in study now. How will we evaluate all of these novel therapies? There's not enough patients to go around, especially if, say, the regulators want comparators for the T cell engager studies, for the cell therapy studies. So I had this discussion with my research staff back in the spring, just when baseball season was starting. And I looked up my calculus. Yeah, I took 3 semesters of calculus many years ago at Cornell. I don't remember a single thing. So this approach to discussing regression to the mean failed with my research staff. So then I resorted to baseball because after all, it was April. And I said, you look in the paper and you can see baseball hitting averages. The batting average is about 800 for the first week, but there will be a regression to the mean. So by the mid-season, 250, 300, they were not baseball fans. They had no clue what I was talking about. So then I just said, life is not perfect. And I think this is very important. I remain cautious about all of these types of therapies. We need to study them in larger numbers of patients and see what the exact efficacy is, what the exact safety is. So I think the winner in this approach to deplete B cells, I think we need clinical autonomy without dependence on other specialists. Obviously, efficacy, safety, and durability are important, None of us in rheumatology are crazy about a lymphodepleting regimen. We want to make sure whatever therapy we use does not affect fertility. And I think it's key to be able to administer these therapies as an outpatient without hospitalization. And cost, there's no question there. We can't spend $500,000 on each patient. So I always wondered what the letters CART stood for. You know, was it chimeric antigen receptor T cell, or was it a cure-all for rheumatology treatment? And we'll see, the data have been so amazing, but we will see as we move forward with more studies. So I thank you very much.
Thank you very much indeed, Rich, and indeed once again to Georg and Carl. Well, I think we would all agree that that has amply met my prediction of a simply outstanding series of presentations. So thank you so much. We do have some questions and answers. Such is Georg's energy that he's already started answering some of the questions online. So thanks, Georg, for typing away and doing my job for me. I'm going to take one or two of the questions, though, and I may even actually, Georg, with your permission, I may even come back to a couple of the ones that you've already typed in some answers, because there's some nuances I'd like to pick up. But I'm going to start actually, Carl, with your good self, and Chris Baldiviano has popped in something in the, what is the role of the endogenous T cell receptor and cell persistence of CAR T cells? And would you expect similar persistence in allo, many of which are TCR knockouts, if everything else in the construct stays the same? So great question, Chris. And Carl, maybe you could think out loud about your thoughts there. Thanks. And maybe our backroom team can take Carl off mute.
I'm off mute now, I think.
Oh, good man. That's great. I love it when the technology goes so well. Carl, over to you.
Thanks, Ian. You know, it's a really good question. So, in general, the CAR can signal autonomously, you know, independent of the T cell receptor. So you can, for instance, you know, show a T cell, a CD19 target, and then that will trigger proliferation of the CAR T cell, daughter cells, and a cytolytic activity. You can also take, for instance, if that CAR cell is also CMV specific through its TCR, you can present its CMV antigens on the correct HLA molecule, class 1, and it will proliferate. So the T cell receptor continues to work in CAR cells, and in fact, that's been used in some ways to boost CAR cells. So you could, you know, if you have, and there are some investigators, for instance, Helen Heslop at Baylor, they've used viral specific T cells, such as, you know, those that see CMV and other viruses, and then they have, after they expand those with antigen presenting cells, and then they transduce the CAR in, and then they infuse those into patients. They can boost the CARs through their viral TCR. So then that brings up what the, you know, the question was asked. I think when you have allogeneic cells, those are, you know, usually the T cell receptor is edited out so that it won't cause graft versus host disease. And then, so that then would be very different than the autologous cells. But then there are some CARs where sometimes they co-isolate with the T cell receptor chains. And then, so anyway, it can get complicated depending on the design of the CAR.
No, thank you. And I have to say, your background explanation of the whole range of CAR, it really is a playground for people who like mnemonics, isn't it? Yeah, an armored car and a truck and all the rest of it. I think we're all in jealousy of the great names for these therapeutics. Just as a quick follow-up, your Nature paper around the type 2 cytokines was fascinating. Of course, some of these molecules are produced endogenously in the context of autoimmunity. Of course, if there's no autoimmune disease, maybe they're not being produced. But let's imagine they were being produced. So that you do get a sense that maybe particularly I'm thinking IL-4, IL-10, some of the other type 2 cytokines, and the potential impact they may have on the CAR T cell itself. Any thoughts, Carl? Georg may be thinking about this in the background as well. But Carl, any first thoughts you have of whether the context of the inflammatory environment is actually having some play on how the CAR Ts are behaving?
Well, I think, so first of all, that data we had was on pediatric and young adult patients with pre-B cell ALL. And we don't know if it will apply at all to even another cancer population. And so these were people who had active thymuses, I mean, they were young enough that they're still making T cells, which, are, the older patients may not be. And so we don't know why some of the patients had elevated, for instance, IL-4 in the serum before treatment, whether that reflects some allergic component, and then that makes you a better candidate for CAR therapy. And we have no idea then if then how that would impact, as you said, I mean, some of these autoimmune cases where there's elevated levels, would that make the CAR cells be more toxic, or would they work better? There is a very interesting pharmacokinetics effort that Georg Schett has shown, which is the lupus patients in general that he's treated have recovered their B cells.
Yeah.
And the construct that he's using is very similar to the one that we use all the time, where we have long-term. So we don't know why that is. We just don't know whether that's an issue with background cytokines or the autoimmune issues that T cells aren't the same in an autoimmune patient as they are in a healthy patient. So there's a lot to learn.
That's a lovely segue, actually, just to bring Georg in, partly on that point, but also, as I said, Georg, you've been doing a fabulous job in pinging a whole lot of answers up online, but maybe I could just tease out of you a conversation about that, about the level of depletion, the rate of recovery, and then maybe if you could segue there into, and again, trying to pull together several of the different questions. Actually, why don't you start there, and then I'm going to lead into another question about immunological reset. There's a lot of interest in that concept, but just first and foremost, just the dynamics of cellular recovery, which do look pretty brisk compared to some of the hem-onc data sets.
Yeah, I mean, regarding the cellular recovery, it's really interesting, right? That the cellular recovery is very consistent and usually often faster than with monoclonal antibodies depleting B cells, right? That's very interesting. So we have data that they can recover after 40 days, which is rather short, it's definitely these B cells have CD19 on the surface, right? So they are not escaping the CAR T cells, right? They would be susceptible to killing again. So that means that the CARs just disappeared. And why they disappeared is not fully clear. Of course, they have no antigen stimulation because probably the system is completely depleted of CD19 B cells, but there must be other reasons also. And I think one reason is that in autoimmune disease, you usually have a hyper-regeneratory bone marrow, right, which is very strong bone marrow resource. And this comes back and this outpowers, I think, the residual CARs. So that is probably the reason, but why it's so different from oncology, because as Carl mentioned, in these patients, some of these ALL patients, they got a lot of chemotherapy before also. And the other component is the depth of depletion, and it brings me also to Rich's point, right? It's not clear how deep you need to deplete, right? In oncology, probably one surviving cancer cell can replenish the system. The question is, I mean, in lupus, you probably need to eradicate the autoimmune clones, and you don't probably need to eradicate the last B cell. So this is an open question, how deep you need to go. I think for a long-term remission, you need to have quite good depletion in secondary lymphatic organs, right? It's not sufficient just to deplete in the circulation.
And just to that, Rich, I'm going to ask you to come back on that just momentarily, but just if I can again pull several of the questions together, and it's around this concept of immune reset. Because most of us look, and several of our questioners are saying, this is arduous, this is hard work. We have now seen ICANS. We've seen so far reasonably moderate CRS, but the reality is this is going to be toxic in the long term. There's going to be events, but it's a risk-benefit ratio, and that's what's so exciting. But if the prize is immunological reset, then that risk-benefit ratio conversation becomes, it really does shift the balance. So let me ask a synthesis of about 3 or 4 questions in one go. You've got the same HLA, the same patient, probably by and large in the same environment, although I love your idea, by the way, that they don't consider themselves patients. So they're people who used to have a disease. So and I really love that, by the way. I thought that was a beautifully made point. But they do still have the same genetics, the same environment. They've added to that, presumably, some level of molecular tissue damage, which I think Rich is reminding us of. And yet, so far, we're not seeing recurrence. And I mean, is this just simply clearing out that bit of the repertoire that potentially was autoreactive? Because that also feels, it's hard to conceptualize that, because the same worry would then mean, are we creating I remember the olden days. Remember, we used to talk about holes in the repertoire. Well, that same worry would pertain to the risk of infection. So, just if you could expand a little in your thoughts about what is the concept of reset in that same individual who's got all of these predisposing factors?
Yeah, I mean, I think that was actually also our consideration, that you basically keep the genetics, right? And you keep potentially also the T cell pathology. And that could actually educate the B cell system in the same way as it is done before. But that doesn't happen so easily, right? And it probably shows also this multi-step generation of autoimmune disease, that when you create actually certain checkpoints again, that they do not automatically go into autoimmunity. And this is, I think, one observation is very interesting, that these patients get infections, of course, like everybody gets infections. These patients get into the sun, so they have the usual triggers now, right? And they don't automatically trigger the onset of autoimmunity. So I think the re-establishment of checkpoints is pretty crucial. I personally think also there is more than just taking away the antibodies, right? There is actually also, I think, a strong change in the lymph node antigen presentation, in the T cell functional state, which happens. And this complexity, I think, is reset. The term reset is actually created by the fact that you don't need the therapy anymore and the patient has no autoimmune disease, so it's somehow resetted. But to define the reset will be a future goal. It's not defined, I would say.
No, it's very well said. No surprise, Georg, given my interest in the world, that presumably there is some innate immune component going on here. There's some impact on so-called trained or learned innate immunity. I don't know that is as well defined as it needs to be for this. And you also loved your comment in the chat. You know what? So far, we haven't seen a whole lot of this recurrence yet. So to some extent, we need to explain the possibility rather than the current regular reality. But Rich, I want to bring you in here. In no way, by the way, did you burst the bubble. You gave us such a beautiful, reasoned and balanced. But maybe you could pick up the clinical side of Georg's comment about the depth of B-cell depletion and potentially those pros and cons in your mind. What are your thoughts about that clinical comment about depth of depletion? And if I could maybe ask you to think also about the implication that might have for adverse events. Several of our questions are focused on the risk as much as the potential benefit.
Yeah, I see a question to me about infections, but we'll come to that in a second. So if you contrast rituximab and obinutuzumab, there's no question about the degree of B-cell depletion. And using very high sensitivity flow to lower limit of detection of, say, 0.4 cells per microliter, obinutuzumab wins hands down over rituximab. So the question is, is that what was responsible for the better response rates in the Nobility study? And I can't really talk about the Regency study, which is the phase 3, but there was that press release that I showed. So yeah, I think more is better. The question is, what is the ultimate? And do you pay a price for getting more and more aggressive? And I don't think we know that just yet. So with obinutuzumab in the phase 2, and that addresses the question that was asked of me, it says, how do you explain the standard of care plus placebo group having more infections than the OB group? And though it says Regency in the chat, it's really the Nobility trial because the Regency data are not out yet. So that's actually what we saw. We saw a greater number of infections in the standard of care group compared to the obinutuzumab group. And I think it speaks to how surprised we were decades ago. We were scared to death when we designed the LUNAR trial, the Explorer trial, rituximab in proliferative nephritis, and then also in regular SLE. What's going to happen when people don't have B cells? But we've learned our lesson that you can live without B cells and live well. So,
yeah, I guess evolution should have taught us that the immune system has probably learned a thing or two over the last several million years, and there's some fail safes built in. That's a great point. Just we're drawing towards the end of our time together, but I'm interested, Carl. Maybe if you wouldn't mind me coming back to you, but Georg or anyone may feel like chipping in. We hear a lot about off the shelf, about shorter half-life to development of medicine. Could you just share maybe just a little more insight into, autologous, allogeneic, off the shelf, as opposed to potentially increased risk and benefit? Because a lot of our questions are clearly people saying, this looks great, but what if? So maybe, Carl, if you could just share a couple of thoughts. And Georg, I'm going to come to you also. Gentlemen, we have a couple of minutes. So I'm looking not only for your brilliance, but also your concision in the response. So, Carl, you first, please.
Well, I mean, this is the subject of ongoing trials. They're all really phase 1 trials at this point and not powered to look, and we can't compare. But so the autologous cells that Georg has used have been confirmed elsewhere to have really reproducible activity. There was a study of 3 or 4 patients from China earlier this year in Cell, where they treated patients with allogeneic off-the-shelf cells where they had done multiplex editing with CRISPR, Cas9 to knock out like 4 genes, the T cell receptor, beta-2 microglobulin, et cetera. And then they made a batch of those cells from one healthy donor and then treated 3 or 4 patients, all with the same group of cells, and the patients all responded. And they had engraftment for about a month with those allogeneic off-the-shelf cells, and then they disappeared. So that in principle should be cheaper, and whether it would work as well, whether it would be as safe, we do not know. But the other approach, really is going to be in vivo delivery. And there are companies now giving in vivo viruses to make CAR T cells in the patient or lipid nanoparticles. And all of these are going to be compared and then compared again to things like bispecific antibodies.
It's a hugely exciting field, it has to be said. Georg, I've got to ask for your own thoughts on this matter as well, please.
Yeah, I think it's interesting because you don't need, as we talked, you don't need this long-term presence of the CAR, right? And the allogenic usually has not this long-term presence, and that could be this can be sometimes a problem in malignancy, but here it would be not necessarily a problem. So in fact, if they get enough cells made and that they kill the B cell population, then it might work, right? And you don't need long-term presence. And that might be also interesting for the in vivo CAR, as Carl mentioned.
Yeah, and Rich, you made the interesting point, which I suspect most of us would agree with, which is this will start in refractory. But actually, if it does turn out that tissue damage is acting as a kind of, let's call it almost a tissue adjuvant type effect, I mean, maybe this needs to be used really, really early. And, in rheumatoid, we now freely talk about pre-RA. We've known for a decade more, I guess, about the prodrome in lupus and. I mean, what do you think about that timing, Rich, going forward? I mean, if we did have data that something was more off the shelf, potentially more economically viable, where could this go in your thoughts?
I think it all depends on safety, but if proven safe, then yes, I think we will use it more to the left. And I describe the pyramid from rheumatoid arthritis to my young faculty and trainees, and I talk about gold, except they have no clue what I'm talking about, but how those therapies were replaced with biologics and earlier use of biologics. So I see the same thing happening in lupus.
Yeah, Rich, just so you don't feel so bad, I had to show this to my children recently and explain it was a pen. They had no idea what that was, so I had to show them this and say it was paper. Listen, with advancing maturity comes great wisdom. And with that, I'm going to ask our wonderful back team staff to bring our summary up, because it transpires that our time is up. And I want to make sure that I just reserve a couple of minutes to thank you, our audience, for being with us, to thank the backroom staff. Here we go. The backroom staff who have made the technology almost McInnes proof. I can still press the odd button and make a mistake, but the rest of my learned faculty navigated the technology beautifully. So thanks for being here. Please do fill in the short evaluation form that you will have made available to you shortly. We'd love to know what you think, good and bad, and we will use that information to continue to provide what I hope are valuable webinars for our continued education. And please remember, the on-demand version of this webinar is going to be available on the IMID Forum YouTube channel. And if you do such things, go there, enjoy, leave a bit of feedback as well. You're always welcome at the IMID Forum. Thank you for our sponsor, BMS, who provided some wherewithal to allow us to bring this incredible faculty together. And if you want to, there's going to be some podcasts here highlighting some key messages. You'll have the joy of me listening to and learning from Georg again. I've spent many, many years listening to and learning from Georg, and I'm going to get the chance to do it all over again in a podcast. What's not to love? So with that, ladies and gentlemen, thank you so much for joining us in this webcast. Thank you so much for allowing us to share time with this incredible faculty, to Carl, to Georg, to Rich. We have learned, and we will take forward the messages we have heard. And honestly, this is such an exciting time. We're at a threshold for thinking differently about the management of autoimmune disease. And whether it's CAR Ts or CAR T cells plus the other modalities that Rich has brought to us, I don't yet know, but what I do know is that as we learn, we're going to improve outcomes for the people who really matter. That's the people with these diseases. And with that, I'm going to bring this webinar to a close. Thank you all. Good morning, good afternoon, good night.
Thank you.
Bye.